that will be led by Dr. Justin Garson. The main focus will be on a recent shift that has happened in psychiatry. And for attending this lecture, The End of Psychiatry, Madness, Medicine, and Mental Health. So since the 1980s, the disease model regarding mental illness has become entrenched in psychiatry, but also in our collective imagination. In this medical model, mental illness is considered like a dysfunctional state, and then the role of the psychiatrist is in the end to find this dysfunctionality and then to fix it. However, Dr. Garson will present a different and alternative view called madness as a strategy. And this vision stretches back to ancient times, and it sees madness as purposeful rather than pathological, and it sees it as designed and not diseased, and it sees it as functional rather than dysfunctional. After an initial historical overview, Dr. Garson will also describe some current research projects that embody this idea. And finally, there will also be some reflections about the ethics of this vision. This talk is organized by Britt-Me Par as part of the Human Rightivism project, which is supported by the Swedish Embassy and implemented by the Community Development Fund. So, as a short biography, Justin Garson is a professor at Hunter College and the Graduate Center, City University of New York. He has authored several books. One of them is Madness, a philosophical exploration, The Biological Mind, and also the upcoming book, The Madness Pill, The Quest to Create Insanity and One Doctor's Discovery That Transformed Psychiatry. Dr. Garson also contributes to psychologytoday.com, EON, and also madinamerica.com. I am Janko Njupsa, a teaching assistant at the Department of Psychology, your moderator for this event. So, Justin, please, the floor is yours.
Turn on. Thank you. Thank you so much. Okay. All right. Just let me know if there's any problem with the volume. First, I want to just thank you so much for being here, and I want to thank Britt-Me Par for inviting me and bringing me out here from New York. It's a real pleasure and a real honor to be in Pristina, and I'm grateful that you're here. So today I'm going to talk about what I see as a paradigm shift that's taking place in the way that we think about mental health and mental illness. And it's a shift from what I call a dysfunction framing of mental illness to a function framing of mental illness. You could also think of it in terms of a shift from a pathology framing to a purpose framing, or shift from a disease framing to a design framing. So I'll first just spend some time using examples to illustrate what I mean by function and dysfunction perspectives in psychiatry, and then I'll talk about some of the broader implications of the shift, not only for research, classification, stigma, but also for what it means to be diagnosed as having a serious mental illness. And I'll start by saying what motivated me to get interested in the topic of mental health. I have a lot of mental illness in my family, as I'm sure some of you do as well. In the 1970s, my dad was diagnosed with paranoid schizophrenia. Now, he worked under the American president, Richard Nixon, and Nixon was kind of famous for making his staff members insane by spying on them. So I think that might have been what happened to him. In the 1980s, he was re-diagnosed with bipolar disorder. He often heard voices. He thought God was speaking to him. He thought that the French actress Catherine Deneuve was speaking to him and in love with him. And it was such a normal part of my upbringing that I started to think it was pretty ordinary to hear voices. And I started to think maybe it was just not a disease or a dysfunction, but just a different cognitive style. And in fact, there's an organization called Hearing Voices Network, and they actually work with people who hear voices and help them to experience their voices as a source of insight, as a source of creativity, as a source of comfort. And some people have benefited greatly from having this very different perspective on voice hearing. So I started to think, even when I was pretty young, that this whole medical approach that looks for disease, dysfunction, disorder, maybe it was making people worse off in some ways. And then when I was 16, I got very depressed. I was thinking a lot about suicide. And so my mom got very worried. She brought me to the hospital. And I ended up staying in the hospital for about 6 weeks in a teenage psychiatric ward. And at the time, I was led to believe that my depression stemmed from some kind of a brain dysfunction. There was something wrong with the way that my brain worked, and that pills like Prozac could help to reverse that dysfunction. And I suppose that framework did some good for me, but it was also negative in a way, because I always grew up with this idea that there was something wrong with my brain and that I needed a doctor to come and fix it for me. But during this time, I met a lot of teenagers who had different problems, but when they told me about their home lives, when they told me about some of the abuse or trauma that they experienced at home, then some of the problems that they described, like depression or drug addiction or personality disorders or self-harm, cutting themselves or burning themselves, it was easier for me to see, not in terms of something going wrong with their brain, but in terms of a relatively normal response to a pretty terrible situation at home. And I started to think again, well, what if this whole language of disease, dysfunction, disorder, what if it actually makes people worse off in some ways by giving people the impression that there's just something not working right inside of them? But I didn't think much about those issues until about 10 years later, when I was a graduate student in philosophy. And I came across a little book called Why We Get Sick, and it was written by a psychiatrist. And the basic idea behind the book is that we'll never really understand health or disease until we look at it from an evolutionary point of view. But, the book says, when we look at disease from an evolutionary point of view, we'll see that a lot of the things that we think of as dysfunctions are actually functional. Instead, a lot of the things that we think of as diseases are actually part of the body's design for helping us to live well. And one of the examples that he uses to illustrate this is fever. Until about 1700, a lot of doctors thought that fever was a disease, that when a patient gets very hot, that fever itself is a kind of disease that you need to fight. And so they would fight against the fever by using drugs, by bleeding the patient, by making the patient vomit, to try to get the fever out. And then around 1700, there was this paradigm shift. People started to think that fever, far from being a disease, was actually part of your body's designed mechanism to help you fight against infection. And now that's a basic understanding, that fever is there to help you fight your body's infection. It's not a disease at all. And that really changed everything about how we deal with fever, because we don't really think of fever anymore as something that you have to fight, get rid of. The fever is the thing you want to work with in order to help heal. So in this book, there's this one chapter, and it's called are mental disorders diseases? And the author says, no, not all of them are diseases. Some of them, like fever, are like your mind's designed mechanism to help you deal with the situation that you're going through. And one of the examples he uses is depression. And that really spoke to me because of my history with depression. So I'll share a little bit about what the book says. The book says that we often think of depression as a kind of brain dysfunction, maybe a chemical imbalance that could be reversed using drugs like Prozac. But instead, they think it's part of your mind's designed mechanism for dealing with a life situation. They see it as part of your mind's attempt to show you that something in your life isn't going well and needs more attention. It might be a job, might be a career plan, might be a relationship. They think it's like your mind's attempt to get you to detach from a certain life goal. But the point is that it's purposeful. It's not pathological. It's by design. It's not a kind of disease. And at the time I read that, I thought, this book is so subversive. I had never heard anything like this in my life. And it seemed to have very deep implications. It seemed to mean that, okay, if depression really is designed to help us, then the best path forward isn't always to, bombard it with medications, but it's to listen to what it's trying to teach us. And that doesn't mean that pills have no role. I think pills absolutely do have a role. But it seems to me that on this theory that pills mainly have a role in helping us manage our emotions to the point where we're able to really try to listen to depression or try to figure out what aspect of life it's trying to get us to pay more attention to. And so I started to get very fascinated with this idea of mental illness as being functional rather than dysfunctional. And I wondered if anybody else in the history of psychiatry, in the history of madness, had ever had this point of view. So I started going back through psychiatry's history to look for this design perspective. And the first person I thought of was Freud. Now I know that Freud had a lot of ideas that were probably very wrong, so I'm not embracing anything he said, but he had some similar thoughts. He often thought that when somebody has what we would call a mental illness, there is some kind of a purpose being performed. There is some kind of a function being performed. And he thought that the doctor's job is to figure out what purpose was being performed and then to try to use that information to help the patient. And he would often get angry at his colleagues in medicine for being unable to see that what they called delusions or hysteria or obsessive thoughts, for failing to see that these had some kind of deeper purpose or deeper function. And then I kept going back through history. Another thinker I found was Philippe Pinel. This was about 1800 in Paris. And he's mainly famous for bringing these humanitarian reforms into psychiatry. So there's this famous painting of him breaking off the chains of the mad patients at the Paris asylums. And it's true that he brought about some powerful reforms, but he also had some very radical ideas that a lot of historians don't know about. One of his ideas was that certain kinds of psychotic episodes were kind of like fever. He thought that they had a healing, cathartic quality, and he actually thought that in the best of cases, when somebody was having a psychotic episode, it should just be allowed to run its course in a safe environment. And this was completely against the medical wisdom of his day. In that time, if somebody were having a psychotic episode, medical wisdom said they should be restrained and put into a dark room. which I can't imagine anything more terrifying than being restrained and put into a dark room if you're already kind of detached from reality. At the same time, there was a German doctor around 1800, Johann Christian August Heinroth, and he had a similar point of view. He wrote this massive medical textbook, about 800 pages, and it's true that he has this very medical perspective. He generally thinks of mental illnesses kind of like diseases. But about halfway through, he starts describing this one particular kind of illness. And he says what happens is that when life becomes too difficult, when a person's going through a lot of trauma or difficulty, it's as if nature somehow detaches that person from the world. Nature causes the person to enter into a kind of dream world of hallucinations and delusions, and it's there for a purpose. It's there to protect the patient from experiencing these awful, the awful things that they're going through. And he too thought that in the best of cases, this kind of psychotic episode would run its course and then the patient would get better by themselves. And my explorations led me finally back to a book written in 1621 by Robert Burton. It's called The Anatomy of Melancholy. And Burton was a scholar and a philosopher and a theologian. And he wrote a lot about melancholy, which was kind of like depression. It was kind of the earlier concept of depression. Now, Burton was very religious, and a lot of the people that in his culture were profoundly religious. And one of the core questions they would ask is, well, why would God allow madness? Why would God allow melancholy? And the answer that he came up with is that perhaps madness is part of God's wake-up call. Maybe it's like God wants you to see that something in your life or something about the way that you're living isn't working out and that you should make certain life changes. And I think it's natural when people read Burton today to say, well, this is a terrible point of view, because effectively he's saying madness and melancholy stem from some personal failing, some kind of a moral failing or a character flaw. And I think they're right. It is a terrible point of view in that way, and it's awful to suggest that depression is some kind of a character flaw or moral failing. But I think if you can look past that, there is a very deep insight in his book, and it's similar to what the author of Why We Get Sick was trying to say, that it could be at least sometimes some of the things that we think of as mental illnesses are really trying to get us to see that something in our lives isn't working out and to prompt us to pay more attention to it or to make some life changes. So all that to say, I started to think that a lot of the historians of psychiatry had gotten things wrong. I don't want to say they got things wrong, but at least they had a very limited point of view. You know, often when historians of psychiatry talk about the past, they describe it in terms of a clash or a confrontation between these two main points of view. There's the biological point of view and there's a psychological point of view. So they'll say something like this. In the early 1800s, people had a more psychological point of view, and then in the late 1800s, they had a biological point of view, and then in the early 1900s, they had a psychological point of view, and now we've gone back to a biological point of view. And I think there's some truth in that, but I also started to think that it was quite limited, and I started seeing the history of psychiatry not so much in terms of a clash between a biological point of view and a psychological point of view, but a clash between these two perspectives, the dysfunction perspective and the function perspective. And I called the first madness as dysfunction, and I called the second madness as strategy. But that's why I say you can also describe them as a pathology versus a purpose perspective, or a disease versus a design perspective. So I'll just describe the basic idea behind madness as dysfunction and madness as strategy, and then I'll talk about some of the current research that I think illustrates these ideas. So the basic idea of madness as dysfunction is very simple. The idea is that when somebody is mad or somebody has a serious mental illness, it's because something has gone wrong inside of them. Something inside of them has broken down, kind of like a broken machine, and the doctor's job is to figure out what went wrong and to fix it. In contrast, in what I'm calling madness as strategy, the idea is that when somebody has a serious mental illness, it could be that everything inside the person is working exactly the way that it's supposed to. Could be everything inside the person is working exactly the way that it should, and somehow the doctor's role or the therapist's role is to figure out exactly what that purpose is and to somehow use that knowledge to help bring about healing. And there are two reasons why I think this way of reframing psychiatry's history can be very useful, not only for psychiatrists and psychologists and therapists, but also for people who have been diagnosed with serious mental illnesses, whether schizophrenia or bipolar disorder or depression or personality disorders or anxiety disorders or whatever it might be. First, I think this language of dysfunction and strategy gives us a framework for making sense of some of the most exciting research problems taking place today. I've been fortunate enough to write about a lot of this research for Psychology Today and to meet a lot of the scientists who are doing it. And so I'll just describe very quickly 4 different projects that I think really illustrate this madness as strategy point of view. The first, which I already mentioned, is depression. Back in the 1980s, 1990s, it was very common to see depression as a result of a brain disorder or as a chemical imbalance in the brain. In contrast to that, as I mentioned, some psychiatrists tend to think of depression as your mind's signal that something in your life isn't working out and it needs more attention. And at least some of the psychiatrists that I've talked to believe that they've used this idea with great success to really help improve people's lives, and that it should be more a part of our collective understanding of depression. A second example comes from the whole realm of what are called the personality disorders. For example, borderline personality disorder. Borderline personality disorder, or BPD, is associated with a lot of different traits: a deep mistrust of other people, difficulty with interpersonal relations, sometimes impulsiveness, sometimes self-harm, like cutting or burning yourself. And there was a time not long ago where many doctors thought of BPD as the result of a brain defect. Something has gone wrong in the frontal lobe and it needs to be repaired. But more recently, and I think that this is becoming the mainstream point of view, a lot of people are starting to see BPD not as a brain dysfunction, but as a survival strategy. There's some evidence that up to 80% of people who have been diagnosed with BPD have a history of abuse, neglect, or trauma in their lives. And from that point of view, it becomes much easier to see mistrust of other people as part of a survival strategy, as a kind of personality trait that you might have had to take on in order to just deal with the realities of day-to-day life. And if that's right, I think two things follow. First, we should get rid of the disease language, the dysfunction language, the disorder language, because that could just reinforce the idea that there's something wrong with my brain. But then secondly, a key to therapy would not be, okay, let's look for a hypothetical brain disorder, but rather, let's see why those strategies that might have made a lot of sense at one point in your life, maybe those strategies aren't helping you very much now. Maybe those strategies are starting to become obstacles to your life. A third example comes from the study of delusions. Delusions are effectively strange beliefs that have no social recognition. So the belief that I'm the second coming of Christ, or the belief that an actress is speaking to me, projecting her voice into my mind or something like that. It might seem obvious that delusions must result from some kind of a brain disease or a brain dysfunction, but there's another point of view that some psychiatrists are promoting, and that's the point of view that goes back to these older times, which is that the delusion might be performing some kind of an important role in your life or playing some kind of an important function. And some theorists believe that delusions are protecting you for some kind of a realization that might be too difficult for you to bear at that particular time. So there's some evidence that delusions may give us a sense of purpose or a sense of meaning or a sense of significance that I may be lacking. And again, if that's right, I think that has very powerful implications for therapy, because it means, again, instead of fighting the delusions as if they're a disease, or instead of bombarding it with antipsychotic drugs, the idea is, okay, what role are these delusions playing in your life, and how can we find something healthier that might perform a similar role? And then the final example that I'll mention is dyslexia, but I think the same point can be made about ADHD or about some kinds of autism. Again, growing up, I always thought of dyslexia as a brain disorder that impairs your ability to read or write. So the idea is that part of your brain didn't develop the way it should have, and that means you'll always struggle with these basic kinds of skills. But there's actually interesting evidence that dyslexia might actually represent an evolved cognitive style. It might be a unique way of processing information about the world. So, for example, there's evidence that people with dyslexia tend to be very quick to notice when a painting depicts an impossible figure. So you know the M.C. Escher painting with the staircase that kind of goes on forever. There's evidence that people with dyslexia are very quick to notice that that figure is physically impossible. There's also some evidence that people with dyslexia can be better at what's called divergent thinking, at coming up with multiple solutions to the same problem. So that there's some evidence, at least in the United States, that entrepreneurs, that about 1/3 of entrepreneurs have dyslexia. And if you think about dyslexia as a distinctive cognitive style, that makes sense. Some people seem to be, perhaps they're just better at coming up with solutions to problems, which is what entrepreneurs have to do day in and day out. And it seems to me that if that's right, if dyslexia is a distinctive cognitive style, then we're doing a lot of young people a profound disservice by telling them that their dyslexia is a brain dysfunction. Because think about what it means if I'm told that, okay, I have this brain disorder, my brain didn't develop the right way, and as a consequence, I'll never be that good at reading and writing, and I'll need a lot of additional support, additional help, that can really give somebody a sense of inferiority. But if they're told instead, okay, dyslexia is actually this unique cognitive style, you have this unique way of processing information, and yes, one downside is that you might not be able to read and write as effectively as other people, but there's also these strengths, there's also these gifts that it comes with, then you could really have a sense of, okay, so part of what I want to do is to find a career where my distinctive cognitive style can really flourish and where I can really be successful. And so this leads me to my final point, which really has to do with the broader ethical issues. And let me preface what I want to say in the following way. You know, in the 1970s, in the 1980s, there were a lot of people who thought that this disease model of mental illness would really benefit people because it would really alleviate stigma. The idea was that if I come to see my schizophrenia or if I come to see my depression as a disease, kind of like diabetes or like cancer, then I won't feel blameworthy. People won't blame me for the problems that I'm having. That was the idea, and it was a good idea, and there is some truth to that. But I think in the last decade, there's also been a lot of evidence that this disease model can be quite stigmatizing in a very different way. And in particular, there's evidence that thinking of my depression or schizophrenia or bipolar disorder as a disease can be stigmatizing in three different ways. First, if I think of your schizophrenia, say, as a brain disorder, I'm more likely to think that you are unpredictable, potentially frightening, and that I want to keep my distance from you. Secondly, if I see my depression as a result of a brain disease or a brain dysfunction, I'm more likely to think that it's just a permanent part of how my brain works and that I'm never really going to get better. And then third, if I see my depression as a brain disorder, I'm more likely to think that I need to get pills in order to help it rather than therapy. So I think it leads to a real narrowing down of treatment options. So all this has led me to the following, well, really two conclusions that I want to share with you. First, I do worry that our disease framings of mental illness is not only scientifically questionable, but morally problematic. So more and more, when I see psychiatrists describing mental disorders as brain diseases, I worry that they're doing a real disservice to people and that they could be, in some ways, making people worse off. And then the second idea I want to leave you with is this. Sometimes people ask me, okay, Justin, what are you trying to say? Are you trying to say that nobody has a brain disorder? Are you saying that mental disorders never stem from brain dysfunctions? Are we supposed to treat everybody's problems as if they have some deep purpose or deep meaning to them? You know, maybe my depression really does come from a chemical imbalance. Maybe my OCD or my anxiety disorders really do come from a chemical imbalance in my brain, and the best way to treat it is through medication. Are you trying to deny me the resources that I need in order to get better? And that's not what I'm saying at all. And I suppose if I wanted to really summarize my point of view, I would say the following. I think that people who have distressing or disturbing or just extreme psychological experiences, whether depression or hearing voices or obsessive thoughts or whatever it might be, I think they have a right to be exposed to multiple different ways of making sense of their experiences. So, for example, if somebody ultimately decides to accept a dysfunction or a disease-centered framing of their experience, I want it to be because they had some exposure to a range of multiple different scientifically based frameworks, and they chose that disease framing as the one that best helped them to make sense of their experience. And with that, thank you again so much for listening to me and hearing me out. Thank you so much.
Thank you. Thank you, Justin, for your lecture. So it was very thought-provoking. I'm sure you have many questions. Now we have a question and answer sections. I forgot to mention there's headphones for translation. Channel 1 is Albanian, channel 2 is English. Do të ka edhe kufje për përkthem simultan. E para është shqip, e dyta është anglisht. Gjithashtu mundeni me shtruar edhe pyetje shqip, edhe pastaj e përkthejmë për Justinin. Mundeni përmes ngritjes dorës.
Okay, thank you. Okay, you want to?
First, thank you, Dr. Garson. Elena Yam. So you've talked about your philosophical work, but I wonder if you could also shed some light on the policy implications, if there are any that you perceive thus far, if we're to shift general public consciousness, and what that would mean for school kids and social services, and where your work might intersect or what's being done in the field.
Yeah, thank you so much. I was afraid somebody would ask a question about policy changes, and I'm totally out of my element. So one of the nice things about being a philosopher is that I get to think about things a lot and sometimes write down what I think about. But I do think that it has a lot of profound effects, policy-wise. I guess I feel like my role as a philosopher and as a writer is just to try to get these alternative framings of mental illness out there as much as possible, just into the collective, into the public consciousness. I often have this experience where I'll write something about like dyslexia or BPD or depression, and I'll have people email me and say, you know, I've been diagnosed with BPD for 20 years, and I've never heard this perspective before. At the same time, I'll talk to psychiatrists, and they'll say, oh yeah, we know this perspective. We're familiar with function and dysfunction perspectives, and we present these to our patients. So there definitely seems to me to be a gap between the way that people who are diagnosed with mental illnesses are taught to think about their problems and the way that psychiatrists often talk about them. So I can just say for myself, my main job is to try to just get these frameworks out into the public as much as possible. I will say I did have some very powerful experiences with psychiatrists who reached out to me and said that something that I had written on function and dysfunction framings had been very useful to them in some ways. And so a friend of mine does research on stigma around mental illness. And he said, okay, this way of framing things in terms of you have biological framings and you have dysfunction framings, that was really useful for his research because it enabled him to focus more on the following question. Suppose you have depression and I tell you there's a chemical imbalance in your brain. And suppose you form the idea that there's something wrong with your brain and you'll never really get better. The question he wanted to know is what part of that chemical imbalance messaging is harmful? Is it the idea that my depression is biological, Or is it the idea that my depression is a dysfunction, something is not working right? And so his lab is actually doing research trying to figure out which of these two messages, is it the biological message or is it the dysfunction message? Which of these two messages is really doing harm? So I hope that my work has some benefit, both for patients, but maybe indirectly for some of the scientists who are doing research here. Thank you for asking that.
Hi, my name is Binsky. Thank you very much for the presentation.
Thank you.
Had a wonderful time listening. My question is related to the policy one, so another one. I'm interested in your opinion on what the political purpose is for the biological model. So, for example, to my mind, it's like the consequences are quite obvious. You have someone that is, for example, diagnosed with schizophrenia. They get better, they get pushed into the working environment, and then they get exploited there, or they get worse, and then some family members expropriate all their, their house and all their wealth. And the same goes for stigma as well. Woman gets murdered, it's not labeled a case of femicide, but psychiatrists and psychologists as well sadly line up and call it a case of madness or just crazy behavior that we can't label. So it seems that there is a specific purpose to this biological model, that it keeps labeling individuals as mad, as dangerous, and makes them very easily preyed upon by the current neoliberal system. Is that your opinion as well? How do you figure that this model works in the political framework in which we live in? And also, how do you think that this should inform mental health activists going forward? For example, we have Mad Pride movements all across the globe. How do you think it should be manifested in that regard?
Yeah. Okay. Another policy question. This is a tough group. No. Well, first, let me say something about Mad Pride, because that's really a movement that I'm very excited about and I respect very much. So growing up with my dad and seeing how, in the 1980s and 1990s, really the only thing that psychiatry had to offer him was to put him in the hospital and put him on antipsychotic drugs. And they benefited him in some ways, but they also really hurt him in some ways. And they had some pretty serious long-term negative consequences. And so for me, it's so exciting to see a movement of people saying, okay, I'm mad, I've been labeled with a serious mental illness, but I'm going to think about it in a fundamentally different way. I'm going to think about madness as potentially having some powerful insight or being an important gift in its own right. I think that's a really exciting idea. As far as the first question you asked about, what are the social, political, economic forces that kind of led to the entrenchment of this disease model? That's a very complex question that I only know a very small fraction about. But I'm writing a book on part of this issue. The question of how this disease model became so solidified in the 1980s and 1990s. And I think there are a lot of reasons. One reason is that there were a lot of psychiatrists who genuinely thought that schizophrenia and depression, there was so little that psychiatry had come up with that was useful. And finally, you had this idea that, well, maybe it's just a chemical imbalance. And a lot of them really believed that they were on the brink of curing schizophrenia in the same way that we cure polio or tuberculosis. So there was genuine excitement about this idea that if we could just do a little bit more research on what's going on in the brain, we're going to find some kind of chemical difference. Maybe it's dopamine or serotonin or whatever. So people had really positive motives. One motive, again, was to reduce stigma, the idea that if I can see your schizophrenia or depression as a brain disease, I'm not going to blame you. Of course, in the 1960s, certainly in the United States, a lot of people felt that they were being blamed for their schizophrenia, or even worse, often it was the mother who was being blamed for somebody's schizophrenia. You must have been a terrible mother in order for your child to come out this way. So there were some positive forces behind it, but I think there are more questionable forces. I mean, in the 1980s, when you had the pharmaceutical industry that had suddenly realized they could make billions and billions of dollars, not only by depicting these very severe problems, severe schizophrenia, severe depression, as the result of a chemical imbalance that you can fix, literally cure with a medication, but then convincing us that more and more ordinary kinds of depression were chemical imbalances, ordinary anxiety could be a result of chemical imbalance, ADHD, difficulty paying attention for more than a couple minutes at a time could be a chemical imbalance. So obviously you had pharmaceutical companies that stood to gain, and they still do stand to gain, unthinkable amounts of money by convincing people that this disease model is essentially correct. So there are a lot of different, and then finally I'll just say, and I've been talking to psychiatrists who were working in the 1960s and 1970s, and one of the things they keep telling me is that they really felt inferior to other medical specialties, to other branches of medicine. And so I do think that maybe from a sociological point of view, there was back then, and perhaps still is, this sense among some psychiatrists that this medical, biological, disease-centered perspective gives us some credibility in the medical professions. And that might sound like a very superficial motive, but that's a very real motive. Feeling like you're not respected day in and day out by your colleagues can help to push you in a certain direction. Yeah, thank you.
Well, I think you came to a place where only political questions get raised, so mine is political as well, and it's very much related to the last one. I wanted to know how much of these mental illnesses, disorders, conditions, the whole field of mental health serves some political interests, in the sense of, by political I mean that there are some vested interests in constructing this field of mental health, of creating an industry of pills, of doctors, of psychiatry, and how much of it do you think is historical and it serves some grander political mechanism of power? Let's say if we take Foucault as an example, his history of sexuality, the first seeds start in the 15th century of our current sexuality conceptions. And it really takes place in the 17th century with the classical age. So he says that when we talk about sexuality, we are thinking that we're being revolutionaries, but actually we are serving the same power that oppresses us. So I guess my question is, how much do we take part in our oppression by constructing the whole field and then constructing diseases, illnesses? And I'm not saying that there are people who do not suffer from these diseases, but how much of it is a political construct? And at the same time, it's a depoliticized issue. It makes us understand it in a very specific scientific way. So it depoliticizes it in order to keep serving that higher political mechanism or that historical force. Thank you.
Yeah, thank you so much. And I was wondering if somebody would mention Foucault. So thank you for mentioning Foucault in this context. I mean, you can always, I think it's always important to think about the political dynamics and the power relations in anything, whether you're talking about madness or sexuality or entertainment or anything. There's always a room for looking at what are the power dynamics and whose interests are really being served by looking at things from this perspective. I have a friend named James Davies. He writes on issues about psychiatry. He wrote a great book called Cracked, which is about the influence of pharmaceutical companies in psychiatry. And he recently wrote a book called Sedated, where he looks at the relationship between psychiatry and capitalism. And he makes a point in that book which was really kind of upsetting to me, but I think very true. He said, okay, step back and think about what you would need people to believe in a capitalist society in order to maximize their economic productivity. You need people to be a little anxious and a little depressed all the time because, A, if you're anxious and depressed, then you'll work harder to achieve these goods that you think are going to solve your anxiety and depression. And then there's a whole market where we can sell you drugs or therapies to help ease your anxiety and depression. So you need to be a little anxious and depressed, but not too much. Because if you're too anxious and depressed, of course, you have to stop working. And that must have been the most depressing thing I've read all year, that in order for capitalist society to run well, everybody has to be just a little anxious and depressed, but not too much. Not too well and not too sick. So I don't know what more to say about that, except to note, as you've pointed out, that a certain conception of ourselves as mentally unwell is beneficial from a capitalist point of view. Again, not only in keeping us working hard to obtain these goods that we're convinced are going to alleviate our problems. And here, what he also points out, which I think is true, people often criticize the pharmaceutical industry. Oh, they're just trying to sell us drugs and they're trying to get everybody on their drugs, not just the people with more severe mental illness, but pretty much everybody in society. But it's also the whole mental wellness industry. There's a whole industry that's just there to convince me that I'm doing pretty well, I'm pretty happy, but really deep down I'm pretty anxious and depressed and miserable too. And I just need to, if I just work a little bit harder, or if I buy this book, or if I buy this product, or if I buy whatever, then I'm finally going to be happy. So it's like happiness is always just a little bit out of my reach. And I think that's the whole mental wellness industry is also culpable in making us all feel a little depressed and anxious. Yeah, but thank you. It's a great question.
Okay, hi, I'm Deborah, and I'm a second-year student here at the Faculty of Psychology. And my question is, from your personal opinion, how willing do you think people are to adapt to this new way of thinking, especially people that are not directly affected from mental illness, if I were to say, because as you know, there's this stigma that surrounds it, and also from people that are directly affected because they sort of feel, how do I say this? They maybe find comfort in this mental illness, as you previously said. They may feel happy, but you know that they may think that, oh, this is not the best happy I can get. And so in that sense, how willing do you think that people are to change this way of thinking?
Yeah, that's a great question. And it's hard to say because I do feel like there's just such a gap between, you know, when I write on topics like this, on this particular function paradigm, all of people reach out to me and say, you know, I've been diagnosed with depression or anxiety disorders or personality disorder for years, and I've never heard anything like this. And so in that respect, I think there's almost a hunger for people to be exposed to different perspectives on mental illness. And I do think that I don't know how to say it. I do think that there's an almost endless demand for, I need to hear a different perspective, because I've been hearing the disease perspective for decades and I'm not getting better. And if you look at it, in some ways people are just getting worse off. And I think in the 80s and 90s it was, okay, right around the corner we're going to have a cure for depression. Right around the corner, we're going to have a cure for schizophrenia or for anxiety disorders. And once you've been hearing that decade after decade, you really get tired of it. And it's like, okay, what's the new perspective? So I do think that there is a real demand for different perspectives. And I do think that those perspectives will catch on and will become part of our common language and common understanding more and more. But it's also interesting, as you pointed out, that some people take a lot of comfort in the idea that I do have a brain disorder, or I do have a brain disease, or that for a lot of people that's really important for them to think about things that way. So I've had people sometimes get mad at me and say, my OCD, the only thing that helps me to survive day to day is the belief that there is something fundamentally wrong with my brain. Or I've talked to a lot of people who had undiagnosed ADHD, and then they're 30 years old or 40 years old and they finally get diagnosed with ADHD, and they sometimes feel a profound sense of relief. They think, all this time, there's just been something wrong with my brain. I always thought I was just lazy or stupid, or that there was something, that I was a bad person. And so it does bring a lot of comfort to people, this dysfunction framework or this disease framework. And so that's why I think, that's why I said at the end, I think what's really valuable is for people to just be exposed to different kinds of frameworks for making sense of their distressing or disturbing kinds of experiences. Because I definitely would not, if somebody's tried a lot of things and finally they're told that their ADHD or their OCD is a result of a brain dysfunction, and that truly benefits them, then I certainly wouldn't want to deprive them of that. But I do want there to be multiple perspectives for people to make sense of their suffering. Yeah, thank you. Yeah,
Because of time constraints, we only have time for one more question. So if there's a final question.
Final questions. Thank you. I think your microphone, is it on?
So my question is, can you actually, in reality, observe mental illness from a universal perspective? Because there are cultures that they don't have a concept of trauma, so their experience with trauma is completely different. Even here, majority of the questions were around the collective rather than the individualistic idea of mental illness. We already know that, like for example, the Aboriginal people see multiple colors of red that the rest of us don't. And so, I don't know, what are the dangers when we look at psychiatric concepts from a universal perspective, when our experiences are very much more narrow in society? Yeah.
Yeah, thank you so much. That's a wonderful question about looking from a cultural perspective on mental illness. And when you start looking seriously at how different cultures think about the same kinds of experiences, and you start to see, okay, in some cultures, they don't have the same kinds of problems that we have in the West. That's very powerful and important. So one example that I've read a little bit about is voice hearing. Hearing voices in different cultures, this is a tremendously different kind of experience. So there are places there's been research done in Ghana and in India, or some rural parts of Ghana, some rural parts of India, where people who hear voices and would have been diagnosed with schizophrenia, say in the United States, they have a belief system that helps them make sense of those voices. They think of those voices maybe as spirits of their ancestors, or some kind of a spirit, and as a consequence, they don't experience those voices as being terrifying or as being intrusive. They experience those voices as being more beneficial and as being more helpful, whereas in the West, people generally experience voices as being very frightening and very intrusive, because there's just no real belief system that would help you to make sense of those voices in a meaningful way. So I think when it comes to certain things like voice hearing, we have a tremendous amount to learn by looking at different cultural understandings of voice hearing and then saying, okay, how can we incorporate that understanding for a Western point of view? A lot of Westerners will not think of their voices as spirits of the ancestors, but there are still other ways of thinking about voices in ways that could be more useful or more beneficial. Okay, maybe there are different parts of my mind talking to one another, and if I could just get them to work together better, then I wouldn't have the same kinds of problems. And I think the same is true for trauma. I mean, people experience trauma so differently in different cultures. And I don't know what the right answer is when it comes to trauma or anxiety or depression, partly because there is such a push, partly again because of the pharmaceutical industry, to get these categories and concepts into as many different cultures as possible, to get the idea of depression and anxiety and personality disorders into developing countries to better sell products. And I'm not saying it's all bad, but I do think it's a real tragedy if you're completely ignoring the specific cultural understandings that people have developed to make sense of and cope with these distressing or extreme experiences. But yeah, thank you for bringing in the cultural perspective.
Okay, thank you very much, Professor Garson, for this wonderful lecture. Thank you to all of you for your willingness to ask questions and, of course, your readiness to answer in depth. You will be able to also follow this lecture online with Albanian subtitles some days later. So be sure to follow Brit Me Par for updates on this event. It's been a pleasure listening to your talk, and we look forward to your upcoming book. Thank you very much again.
Thank you.